I'll be speaking on approach to empyema, an important cause for respiratory morbidity and mortality. The learning objectives will be the following: introduction to epidemiology, pathogenesis, etiology and bacteriology, clinical presentation, evaluation which consists of imaging, thoracosynthesis, culture, management which is medical and surgical. The focus will be on medical causes of empyema. Introduction. Empyema is defined as pus in the chest. This is a disease which has been described long ago. Hippocrates is credited with the first description of the natural history and treatment of this condition. The most common precursor is bacterial pneumonia. Imhotep, an Egyptian physician, was first described empyema in the year 3000 BC. Hippocrates understood the importance of draining it. Bowditch and Trousseau first used thoracosynthesis using a needle. Hewitt in 1876 described closed drainage with a rubber tube and water seal. They understood the need, they understood the physiology of the pleural space and the need to keep the pleural space physiology intact. Skede and Fowler in 1890 described thoracoplasty. There was an epidemic of flu in the US, and in the background of that epidemic there were a large number of empyemas and a huge number of and a great amount of mortality. And then a commission was formed called the Empyema Commission in 1917 to look at improving the outcome of empyema. The mortality of empyema was in the region of 30 to 40%. They advised that the pus needs to be evacuated with a closed drainage, avoid early open drainage, and improve the nutrition of the patient. With these principles, the mortality came down to less than 10%. In 1923, Eggers described decortication. We look into the epidemiology. The most important cause is parapneumonic effusions. Now, effusions are seen in 20 to 40% of pneumonias, and out of them 3% develop empyemas. The incidence is increasing worldwide. In the UK, 2.8% per year is the rate of increase. In a study over 8 years done from Canada, they saw about 13,000 plus empyemas. And as seen in this graph, you can see a steady increase in the medical causes of empyema. As we know, the extremes of ages which are predisposed to respiratory infections. But even when they correct it for age, there is an increase in the incidence of empyema. This is also seen in the US. When they looked at the age distribution, they found the following ages showing a greater increase in empyema over the study period: 1 to 4 years, 5 to 9 years, 40 to 44 years, and 50 to 54 years. What are the probable causes? One is the introduction of the pneumococcal vaccine. It was felt that those serotypes which are not covered by the vaccine were beginning to appear. Second is the aging population. As the lifespan of the population increased, it also brought in a population which was vulnerable to respiratory infections. HIV, as we all know, increases the propensity of getting respiratory infections. And the increasing use of immunosuppression for a wide variety of conditions also probably caused an increase in this incidence. This disease causes considerable morbidity. As seen in this study, only 50% do not require medical support, social support, or both at the time of discharge. This is not uncommon in India. A single center over 2 years reported 117 cases. The mortality is around 10%, but Western figures have varied anything between 15 to 30%. So what is the pathogenesis? What are the stages in the development of empyema? 3 stages are described. The first stage is the exudative stage. Here we have low blood counts, low LDH and a normal sugar. The second stage is the fibropurulent stage. Here we have an increase in WBCs, there is increased debris and bacteria, and adhesions and loculations begin to form. And finally we have the stage of organization, where the fluid thickens further and an inelastic membrane called the pleural peel encases the lung. So what are the causes of empyema? Light, in a study of over 319 cases, showed that pulmonary infection is the most common, and the next most common were post-surgical. The others were trauma, esophageal perforation, pneumothorax, thoracocentesis, subdiaphragmatic infection, septicemia, and miscellaneous causes. In a study from the Postgraduate Institute in Chandigarh, they also noticed that bronchopulmonary infections were the most important cause, but they did not find surgical causes very important. And when you look at bronchopulmonary infections, tuberculosis was an important cause, which we did not see in Light series. Other causes are iatrogenic pleural effusion after biopsy, infradiaphragmatic sepsis, which again becomes important particularly because we see amoebic liver abscess quite commonly. To summarize, in the West, pneumonia followed by surgery is the important cause, while in India, pneumonia or lower respiratory tract infection followed by tuberculosis. We will now look at the bacteriology of empyema. It is useful to look at the microbiological data that came out of the MIST trial, which was really looking at the role of antifibrinolytics in the management of empyema, because they got a fairly high positive pleural fluid culture, nearly 60%, but often we see only about 20 to 30%. In them, they found that streptococci were the most important cause, of which Streptococcus miller was the most important. The others were Streptococcus pneumonia, other streptococci, and then Enterobacteriaceae, anaerobes, and staph and enterococci. In the series that came out from India, from the Postgraduate Institute, Chandigarh, aerobic bacteria formed the bulk, but gram-negative organisms were also important. So we had gram-positive, which is only 14%, while gram-negative was 20%. This is also seen from some studies from the Far East. Anaerobes formed a very small number. Superinfection, or probably hospital-acquired infections, caused a different picture, Staphylococcus becoming important, and gram-negative organisms causing the rest. So the difference is that from Indian studies, tuberculosis is important and gram-negative organisms seem to be important. This is another series. Here from the North India, here you can see that gram-positive is important, but this is probably because this series consists of both children and adults. Now, what is the relevance of co-infection? It is often seen that up to a third of patients might have co-infections, particularly co-infection with an aerobic and an anaerobic bacteria. Now, many of these organisms by themselves are of low pathogenicity. So what Shintazhu did was he inoculated mice with Streptococcus miller and an anaerobe, Preptostella intermedia, and what he noticed was individually the mortality was only 10%, but when you combined it was 60%. And as seen in this graph, you can see that the clearance of the organism when there is co-infection decreases as compared to when only the single organism causes infection. The suggested mechanisms are the production of growth factors, that these together prevent phagocytosis and hence increases the vulnerability of the individual. It reduces the redox potential, and under low redox potential the defense mechanisms are affected and it produces toxic symptoms. But combination of infections, particularly aerobic and anaerobic, which is fairly common in empyema, can have poor outcome. It is useful to look at the causes of empyema as suggested by light. Light in 340 patients with 500 odd cultures divided them into community acquired and hospital acquired. This will help us in initiating appropriate treatment. Community acquired Streptococcus species was highest, Staphylococcus aureus, gram-negative organisms and anaerobes up to 20%. Hospital acquired staph, gram-negative anaerobes, aerobes and anaerobes. The hospital acquired or the superinfections reflects what we see in our country too. Community acquired, probably we see more gram-negative organisms than seen in this slide. To summarize, aerobic organisms cause the bulk of empyemas up to the tune of 52%, anaerobic infections probably around a quarter, and mixed infections another quarter. In India, tuberculosis is important. In a series from Taiwan, they found Klebsiella pneumonia. If you see the PGI series also, Klebsiella pneumonia was seen. This needs to be studied further, but we need to keep this in mind. So what is the clinical presentation? We will look at a case here which will elicit which will highlight the presentation better. This was a 48-year-old man who presented with 2 weeks history of fever, cough, scanty mucoid expectoration and right-sided pleuritic chest pain. He had a week's history of progressively increasing breathlessness. He was a driver, he smoked, he drank 2 to 3 times a week, a quarter each time. At the time of the onset of this illness, he was detected to be a diabetic. He was treated in an outside facility with Cefixime. Clinical examination showed him to be quite ill. His respiratory rate was 26, he was febrile and his saturation was 86%. He had clubbing, he had right-sided intercostal tenderness and he had findings of a loculated right-sided effusion. So how does the presentation happen? It depends upon the organism. If it is an aerobic organism, it usually presents acutely with fever, localized chest pain and leukocytosis. If it is an anaerobic organism, it presents insidiously. It is associated but with more symptoms, generalized symptoms like decreased appetite, and the weight loss can be as high as 29 pounds. It is more often seen in alcoholics or in patients who are prone to aspiration. The elderly and the immunocompromised may also present insidiously. In parapneumonic effusions, you can get community versus hospital acquired. You require a high degree of suspicion to anticipate when this effusion is going to become an empyema. If the patient is not responding in the usual manner and if the fever persists, this forms a clue that this patient's effusion may be turning to be an empyema. So let's look at what are the risk factors for progression of a parapneumonic effusion to become an empyema. You can see these scores which are actually severity scores for pneumonia, and you can see except for the Apache 2 score, none of them is significant. So the severity of the pneumonia does not predict whether the person's effusion is going to turn into an empyema. But if you look at these parameters, the albumin, the CRP, the platelet count, the sodium, all these are significantly associated with the development of an empyema. In addition, it is more often seen in intravenous drug users and people who abuse alcohol. Surprisingly, COPD patients are relatively safer from developing an empyema. One is not sure why, but it is possible that these people are seen much earlier and hence they are treated much earlier. So, continuing the same case, you can see in this patient that there is an opacity on the right side which suggests a pleural opacity, and there is probably a loculated effusion. An ultrasound was done and it confirmed that there was fluid. It was aspirated and it was pus. The gram stain was done and showed gram negative bacilli, and the culture showed Klebsiella pneumonia. The counts were elevated with predominantly polymorphs. The sodium was low at 127. The urea creatinine was marginally elevated. The sugar was 300. The liver function test, the only abnormality was that the serum albumin was low at 2.8 grams. So, this patient, as seen in the criteria that I showed you before, had some of the factors which were associated with developing empyema: a low albumin and a sodium which was less than 130. He also had a history of alcohol abuse. So, to summarize, severity score does not predict the development of empyema. Elevated, a low albumin, an elevated CRP, an elevated platelet count, hyponatremia, and alcohol or drug abuse increase the risk of developing empyema. Next, we come to the diagnosis. First, imaging. The chest X-ray, as always, should be the first imaging investigation, and you need to do a PN lateral because, as we know, empyemas may be prone to loculations. To localize the loculation and also to identify subpulmonic effusions, this is useful. The ultrasound is increasingly being recognized as an important tool in the diagnosis of pleural disease, and so also in empyema. As you know, it can be taken to the bedside. It is non-invasive and there is no exposure to radiation, and it can be done often. This ultrasound, which shows different groups. The first one is an anechoic space. The second one shows slight increase in echogenicity. The third one shows very clearly septate, septa formed, and the fourth one, there is fibrosis already beginning. The ultrasound is not only useful to localize the fluid, it is also useful in aspirating. It is also useful in staging the disease, which, as we will see, affects the way you manage the patient. So, like I said, ultrasound is useful to do thoracocentesis. In this study, they showed the safety of using the ultrasound. The risk, the incidence of pneumothorax after a thoracocentesis was less than 3% when an ultrasound was used. They also showed, as you can see, that this depended upon the volume. If the volume of aspiration was less than 800 ml, there was no pneumothorax seen. It is only when the volume exceeded 800 ml that they saw pneumothorax. So, ultrasound is not only useful in localizing, but also increasing the safety of our patients. Let us look at CT scan. CT scan also is useful to stage the disease and localize the disease. It is also useful to know what is happening under the pleura. There was a study done to look at the utility of ultrasound versus CT scan. First, what they did was they compared the ultrasound and CT by asking different observers to score the grades of the empyema using ultrasound and CT. So, they checked the reliability of the grading system. They also saw the utility of diagnosing underlying lung disease, but more importantly what they looked at was, did it change the outcome. So, the outcome was measured by looking at the length of stay, otherwise what is shown here as LOS. Now, you can see that the inter-observer correlation was better by ultrasound with a kappa of 0.7, while the CT scan was not bad, which was a kappa of 0.5. The CT scan was able to diagnose underlying lung disease. Here you can see nematoceles, necrotizing pneumonia, cavitary necrosis, abscess, etc. What they concluded was underlying lung pathology was identified more often by CT. There was good correlation between ultrasound and CT, but the length of stay did not depend upon the findings that came out from the CT scan. Hence, they concluded that CT was not necessary as a routine. So, it is not recommended as a routine. Probably in patients who are going in for surgery to get better delineation of the anatomy and the underlying structures, you need to do a CT. Otherwise, you do not require a CT in the routine management of an empyema. To summarize, do a chest X-ray to confirm, use the ultrasound to confirm, to aspirate and to stage. CT only if you are going for surgery. Next we come to thoracocentesis. This should be done. So, what are the fluid characteristics in the effusion which suggests that the patient may progress to the development of empyema? Light did this very elegant study where he measured the pH, the LDH and the glucose, and you can see that those with uncomplicated had higher pH, lower LDH and higher sugar levels. On the basis of this, he defined the prognostic factors: pus, which is obvious, a positive Gram stain, which is also obvious. But if the glucose is less than 40, if the pH is less than 7, or if the LDH is greater than 3, these increase the chances of developing an empyema. Of course, if the fluid is loculated, the chances are higher, and the culture is positive, the chances are higher. To summarize, thoracocentesis should be done. Complicated parapneumonic effusion, if the pH is less than 7.2, if the LDH is 3 times the upper limit of normal, if the sugar is less than 40, these suggest that this patient may progress into an empyema. There have been other markers that have been looked at to see whether the prediction of empyema, whether they will improve the prediction of empyema. One such marker is the interleukin 8, and it has a very good correlation. But pH, LDH and sugar suffices in the majority. Other markers like procalcitonin, TREM1, etc. have not been found to be useful. For the time being, I think pH, LDH and sugar will be more than adequate. We next come to the bacteriological evaluation. How to culture? Because as I said earlier, except in the MIST study, majority of times we just get about 20 to 30% culture positivity. So, this study was done in the UK, where they looked at the yield of the sample from the parent hospital. They looked at the yield of the same sample from a referral center, here it was the Royal Infirmary, and they looked at the yield by inoculating the sample into a blood culture bottle. And you can see, of course, depending upon the organism, there is a significant increase in yield when the sample was incubated in blood culture bottles. So, the recommendation is: 1. Obtain the pleural fluid culture only from direct aspiration or drainage, not from previously inserted tubes or drains. 2. That you should inoculate freshly drained pleural fluid into aerobic and anaerobic blood culture bottles, in addition to standard sterile containers used for gram stain and culture. And this has good evidence of getting a high culture positivity. Now, we will come lastly to the management. Hippocrates said, if an empyema does not rupture, death will occur, basically saying that we need to drain the pus. Richard Light said, the sun should never set on a parapneumic effusion or empyema. Again highlighting the importance of acting early in a person with a parapneumic effusion or empyema. The basic principles are control the infection and evacuate the pus. So what factors affect the choice of antibiotic? The setting, as we have seen earlier, the organisms are different, whether they are community acquired or hospital acquired, and your choice of antibiotics will depend upon that. Also, we need to consider pleural penetration of the antibiotics. Light did a series of studies in which he compared the levels in the pleural space versus levels in the serum for various antibiotics, and he concluded the best was for metronidazole, followed by penicillin, followed by clindamycin, followed by vancomycin, followed by ceftriaxone, followed by gentamicin. More recently, he has also confirmed that the quinolones, macrolides, linezolid and iratinib have good penetration into the pleural space. From this you can see that probably the aminoglycosides should be avoided unless absolutely indicated. So how do we choose the antibiotics? If it is community acquired, consider using cefuroxime and metronidazole or amoxiclav, because the penicillins have effects on anaerobes, but the cephalosporins do not, and hence metronidazole needs to be used. If it is hospital acquired, as we have seen, staphylococcus is important and gram-negative organs is important. So a staphylococcal antibiotic like vancomycin, and to cover gram-negative organisms like meropenem or piperacillin tazobactam, plus continue anaerobic cover with metronidazole. So anaerobic cover should always be indicated unless we are absolutely sure there is no chance of an anaerobic infection. Macrolides are rarely required, as atypical organisms are rarely cause of empyema. Finally, if you have a positive culture, go by its sensitivity and de-escalate the antibiotic according to the culture report. What should be the duration of an antibiotic? This is a $1 million question. There are no studies which tell us what to do. But broadly, you need to consider the following factors. The organism, if it is anaerobic, you need to give it longer. The control of the source of infection. Supposing you've got a hydropneumothorax with a bronchopleural fistula, you probably have to give it much longer. Or if you have an underlying lung abscess. And the response to treatment. The fluid should decrease, the purulence should decrease, the features of active infection should come down. No studies are available to definitely guide us, because I think one patient is different from the other. The BTS guidelines suggest that we should give at least 3 weeks of antibiotic. Next we come to drainage. You have the following options just to observe: therapeutic thoracocentesis, tube thoracostomy plus fibrinolytic, video assisted thoracoscopy or VAT, decortication and open drainage. So when to drain? The American College of Chest Physicians have given this classification and categorized them into 1, 2, 3 and 4 on the basis of the amount of effusion, the pleural fluid bacteriology and the pH. The pleural space, so if a person has got fluid which is less than 10 millimeters on a lateral decubitus, the culture is negative, the pH is not known, there is no need for drainage. If the fluid is more than 10 millimeters, but the culture is negative and the pH is more than 7.2, there is no need for active drainage. If the fluid is large or the culture is positive or the pH is less than 7.2, the risk of a poor outcome is moderate and hence should be drained. And obviously, if there is pus, the fluid should be drained. When and how to drain? Light has given a classification which is more useful to decide exactly how to treat. It is a little long, there are 7 classes, but it's fairly easy. So class 1, non-significant pleural effusion, the size is less than 10 millimeters, no thoracocentesis. Class 2, a typical paranomic effusion, but the glucose is more than 40, the sugar is more than 7.2 and the LDH is less than 3. Basically no risk factors and the culture is negative. Antibiotics alone. Class 3, if the pH is between 7 to 7.2, the LDH is more than 3 times, but the sugar is more than 40 and the culture is negative, do thoracocentesis and antibiotics. Class 4, the pH is less than 7 or the sugar is less than 40, or the gram stain is positive or the culture is positive, you have to do thoracostomy. Class 5, if in addition you have loculation, then you have to consider thoracostomy plus fibrinolytics. Class 6, empyema, consider tube thoracotomy or plus or minus a surgical option. Complex empyema, there are multiple locules, frank pus, tube thoracostomy, plus or minus fibrinolytics, and often require surgery in the form of VATS or decortication. So observation is not an important option. At least a diagnostic thoracocentesis is required, except if the fluid is very, very minimal and the patient is improving. Therapeutic thoracocentesis, tap. If the fluid recurs after repeated tappings over 48 hours, consider tube thoracostomy. There is only one study which is retrospective and was uncontrolled. Here, in 44 patients with thoracocentesis, only 2 died, and actually if you see, they did better than those who drained using a thoracostomy or with fibrinolytics. And the number of people who went for surgery also was much lower. But this might just reflect the severity of the disease in different groups. But thoracocentesis is an option, but you should take a definite decision within 48 hours depending upon the clinical response of the patient. Next is what size tube to use. You have Poiseuille's law, which says flow is related to the radius of the tube, length of the tube, to the 4th power of the radius, length of the tube and viscosity. So too small a tube, fluid will not drain. If it is very viscous, it will not drain. If it is a very long length of tube, it will not, there will be impediment to the drainage. So what are the factors to be considered? Viscosity, so obviously pus, volume of the drainage if it is large versus small, and presence of loculations. A large bore drainage tube, that is what we defined as greater than 20 F, better drainage, no kinking, but a high rate of complications which can range from 10 to 30%, and some of them could be serious. Pain, injuries, malposition and local infection. Small bore, which is defined as less than 20 F, less severe complications and better tolerated, but displacement, kinking, slipping and even rupture, although they are only case reports, can be seen. You also need to flush the catheter frequently, otherwise it gets blocked. So what do you do with the size of the tube? Large tube for viscous and large volumes, small tube otherwise. You should consider pigtail catheter if loculations in category 2 or 3 on the ultrasound. If small tubes and pigtails should be flushed regularly. How long to keep the tube? It depends upon the response. Usually we wait till the drainage comes to less than 50 ml, and the sediment at the bottom of the tube should be less than 5 ml. What is the role of ultrasound in drainage? We go back to the same picture which shows the different grades: echoic, anechoic, beginning some echoic with no septation, septation and solid. In this study, they found that small bore catheter drainage success was high in those who had complex but non-septate, that is 1 and 2, while 3 and 4 the success was only 50%, and the rate of going to surgery also was higher. So the ultrasound helps you also to decide what is the mode of drainage. Of course, you would drain all fluids and give the patient a chance, but you can predict the possibility of success using an ultrasound. So, the same patient that we went back, we put a pigtail catheter and you can see that it's completely drained and this latest X-ray is completely cleared and the tube has been removed. Now, we look at the use of fibrinolytics. What is the evidence? It was often used, streptokinase was often used, but no one knew whether it worked. So, this study, the MIST study, where you looked at 400 odd patients who were randomized, and what they looked at was the proportion surviving without surgery and the proportion remaining in hospital. And you can see there is no difference between the placebo arm and streptokinase. The streptokinase given was 2,50,000 units twice a day for 3 days. Also, there was a trend towards a higher incidence of serious complications, the most important being, of course, bleeding. There is a second trial, otherwise known as the MIST-2, and here they looked at the use of tissue plasminogen activator, DNase and DNase, either alone or in combination. And what they looked at was the change from baseline in the hemithorax area occupied by the effusion. That was used as the rate of improvement, the rate of surgical referrals and hospital stay. And you can see on all counts, the combination of TPA plus DNase gave better results. The amount of TPA used was 5 milligrams and DNase 10 milligrams. This is seen graphically with respect to the change in the radiological opacification of the empyema, and you can see that it's significantly better in the TPA DNase group. So, when do you consider using fibrinolytics? Not responsive due to multiple loculations, inadequate drainage with tube in position due to adhesions, morbid or unfit for surgery, and when required you use DNase 5 milligrams and TPA 10 milligrams twice daily for 3 years. Surgery. When to consider? Inadequate response at the end of 1 week, persistent fever, patient is deteriorating, multiple loculations, and the patient should be fit. So, this study looked at VATS early in the treatment of empyema. 70 patients were randomized to thoracostomy using VATS or only tube thoracostomy. 17 versus 31% required decortication in those who had VATS. The hospital stay was reduced significantly. Those who had VATS, it was only 8 days, while those who had thoracostomy, tube thoracostomy, it was 12.8 days. And one person had bronchopleural fistula, while that who had only thoracostomy, there was one death also. This is a recommendation of the American thoracic surgeons. In a patient with diagnosis of stage 2-3, according to the American College of Chest Physician guideline, if the patient is fit to undergo operative management, then that is, he is stage 2-3 according to the start of symptoms, consider VAT or debridement upfront. If the patient is not fit for surgery, then do tube thoracostomy plus antifibrinolytics, look at the response. If he is still not responding, then consider VATS or thoracotomy. Decortication is removal of fibrous tissue along with pus from the parietal and visceral pleura. The indication is persistent pleural sepsis, inadequate drainage, thickening with reduced lung function and functional limitation after 6 months. So, it is only for persistent pleural sepsis that we consider decortication early. So, surgery should be considered if the patient is not responding or is actually deteriorating, but is otherwise clinically fit to undergo surgery. Otherwise, the management of empyema is antibiotics and good drainage. As tuberculosis is an important condition in our country, we'll discuss a little bit of tuberculous empyema. As you saw in the study from the Postgraduate Institute, empyema was seen, tuberculosis was seen as a cause in as high as 35% of patients. Various studies from the country show that it is about 30 to 85%, and currently it's come down probably to being the second most common cause. The pathogenesis, it could be due to a rupture of a cavity into a pleural space. It could be due to rupture of a paratracheal lymph node which enters into the pleural space. It could be due to a paravertebral abscess which goes into the pleural space. A pleural effusion very rarely can progress into developing an empyema. Rarely it could be due to hematogenous spread. In the old days when they used to use therapeutic pneumothorax or plombage, those spaces could get infected and then become tuberculous empyema, which would present much later. In the West, that is probably the most important cause, but in our country that is not so. The clinical presentation, it could be insidious onset with fever, cough and breathlessness, or it could be acute because of rupture of a cavity into the pleural space, which causes actually not only a tuberculous empyema, but there may be secondary bacterial infection, and these patients present with features of a hydropneumothorax and bronchopleural fistula. Long-standing disease like the one that I told you after therapeutic pneumothorax etc. can present later on in life as empyema necessitans. So how do you establish the diagnosis? Your X-ray will usually show locculated fluid, pleural thickening with calcification, or when there is empyema necessitans, calcified pleural mass associated with an extra pleural mass. And the parenchyma may show findings consistent with tuberculosis. Fluid analysis shows low pH and sugar with high counts, but not really helps you in establishing a diagnosis. Ultimately, the diagnosis is established by bacteriology, AFP smear, which is more often positive than the culture, and if the patient has parenchymal lesions, the sputum positivity may be also helpful in establishing the diagnosis. In up to half of patients, there is superadded bacterial infection. Treatment: prevent endobronchial spillage, render non-infectious with early diagnosis and treatment, prevent failure by optimizing regimen. The challenges are poor drug delivery. It has been shown by Sahn et al. That rifampicin you can see only 4% in the pleural space, streptomycin only 34% and ofloxacin 48%. There are reported cases where during treatment the patient has developed drug resistance, and it has been attributed to the poor penetration of the drug into the pleural space. Conservative management with tube thoracotomy, ATT and nutrition support is the sheet anchor of management of tuberculous empyema. In this study of 24 patients, what they did was they aspirated every 2 months. Twice a month for every 2 months, and they aspirated it monthly for the next 3 months and less frequently depending upon the rate of accumulation after that. They give anti-tuberculous treatment to up to 24 months because of the poor penetration, and they found that all patients did well, none of them required surgery and all lived. If you look at the study that came out of PGI, where they compared the outcome of non-tuberculous empyema versus tuberculous empyema, again the number of patients that went for surgery were very, very low. The mortality was equal to that of non-tuberculous empyema. The only major difference was the duration of pleural drainage was 55 days in tuberculosis, while in non-tuberculous empyema it was 14 days. The mortality also was quite acceptable, around 10%. This suggests that conservative management works well, and in the majority of patients they do well, but you require a lot of patience, because both from the patient and the doctor, because drainage may be required for as long as 2 months. So, what are the surgical options? Decortication, thoracoplasty, parietal wall collapse, open drainage, myoplasty, omentoplexy and VAT. What are the potential problems related to surgery? Obscuration of the anatomical landmarks by a fibrocalcific pleura makes surgery very difficult and increases the chance of postoperative complications. There may be an inability to do adequate decortication, again for the same reasons. Postoperatively, you may get chronic air leaks, and respiratory insufficiency perioperative is fairly common. In empyemas, tuberculous empyemas, particularly those secondary to pneumothorax therapy, plombage, etc., there have been reported complications. Some of them are malignancy, both non-Hodgkin lymphoma and adenocarcinoma has been reported. Others are mesothelioma, malignant fibrous histiocytoma. Pleural aspergillosis has been reported, and very rarely because of mediastinitis, SVC obstruction has been reported. A word about open drainage. There are two methods. Rib resection, in the dependent area, you cut a few ribs and put about 2 to 3 ribs and put large bore tube inside. The advantage is better drainage and improved mobility of the patient. The other one is an Iloesov flap, where skin and muscle flap is provided as a conduit from the pleural space to the outside. Timing, this is very important, not too early. How do you decide in a long-standing patient with an empyema when to do open drainage? What you can do is you can do a trial with the tube not underwater seal and take an X-ray and also observe him clinically to see whether there is any disastrous change in his respiratory condition. Average duration of drainage is usually 150 days. So, what is advised is that this be used only in debilitated patients not fit for surgery. Surgery is a better option, and this permanent scarring of the chest could happen in such patients. So, the patient is fit, that would be a better option. In conclusion, empyema is an important cause of respiratory morbidity and mortality, is increasing in incidence. Parapneumonic effusions and tuberculosis are the most important causes in India. Organism depends upon whether the infection is community acquired or hospital acquired. The majority are aerobic positive if community acquired and gram negative if hospital acquired. A third are due to mixed aerobic and anaerobic. Treatment is drainage, antibiotics and nutrition. Conservative management suffices in the majority. Consider surgery if sepsis and disease is not getting controlled. Consider early rather than late, end of the first week. Thank you.